Good evening, everyone. My name's David, and welcome to another of ACPP's webinar series and the continuation of a regular set of professional development opportunities that the college is running for paramedics. Before we begin, I'd like to acknowledge the traditional custodians of the land where my Australian-based colleagues are located today and pay my respects to their elders past, present, and emerging, for they hold the memories, traditions, cultures, and hopes of Aboriginal and Torres Strait Islander people of Australia. In recognition that we are a binational college, I take this opportunity to acknowledge the Maori as Tangata Whanaua and Treaty of Waitangi partners in Aotearoa, New Zealand. This evening, I have the pleasure of introducing Robbie King, who's one of Queensland Ambulances' senior LARU Paramedics. Robbie has over 13 years experience as a paramedic and has been working in the specialist LARU field for 7 years. Robbie is currently completing his PhD at the University of Sunshine Coast, with his thesis focused on patient experiences in non-conveyance by ambulance paramedics, and in his spare time works as a peer support officer supporting Queensland's paramedics. Robbie will be discussing the role of LARU within Queensland, how the training is provided, and what experience patients have when interacting with these paramedics. At the end of the presentation, there will be a short Q&A, so if anyone live has any questions, please feel free to write them into the comments section and I'll go through them in the order that they appear. Without any further delay, I'd like to pass the webinar to Robbie. Thanks, Robbie.
Thanks, David. I feel very privileged and honoured to join you today and explain how Queensland Ambulance Service go through the LARU process, and that's probably from my perspective as well. We've all got different opinions how it works, but in a similar way, I think it's apt for me to do an acknowledgement as well. I'm very fortunate to now live, present from this beautiful country in the Sunshine Coast. It's blessed with fresh water, salt water, bush and mountains. And the country's been cared for by Gubbi and Jinnaburra people for tens of thousands of years. So I do extend acknowledgement and respect to the elders, past, present and emerging, and extend that acknowledgement and thanks across to Aboriginal and Torres Strait Islanders across Australia, where listeners may be today. I feel it's also apt to acknowledge in the world of paramedicine, previous paramedic leaders, current leaders and future leaders. Where we are today is in no doubt very thankful to previous paramedic leaders that have moved us through tertiary education, entry levels, and certainly through paramedic registration. Current leaders across the board now in paramedicine in many different fields, paramedic leaders, and including the ACP, the Australasian College of Paramedicine, and the Australasian College of Paramedic Practitioners, all the work that's being carried out to advance paramedicine and in this community paramedic space. So thank you. And I'm very excited about new paramedics coming through the system. The privilege of working in universities, and the new paramedics coming through, the enthusiasm, the ideas they have help us move forward as a profession. And certainly there seems to be a lot more interest now, I've noticed, in the community paramedicine space, and that's growing. So just like to acknowledge those people. As David said, I'll just rush through this. So this is the role of LARU with Queensland Ambulance Service. I'm just going to talk about a little bit of my journey, the education, the scope of LARU, some local pathways we have, and if I'm a little bit cheeky, talk a bit about my research and how that sort of links into where I am in this space. I just wonder if the story is familiar to some of the listeners. So I started 2009 as a paramedic in Metro and rural stations working on a traditional ambulance. Since then, I've had various roles here and there within the ambulance service, but primarily working on an ambulance, attending to patients calling us for unscheduled healthcare. In 2015-16, I had a little bit of an opportunity to go out to Nepal post the earthquake there, assisting with some health clinics and primarily trying to assist some local reliance in remote regions, setting up first aid education for local health volunteers. And around that time, I also took 18 months out to go into tertiary education. And these experiences and my experience as a paramedic really began to sort of play in my mind, sort of what is the role of a paramedic. We recognize most of the cases that we go to aren't the emergency resuscitation type cases that we seem so honed for and trained for. And I did get a little bit disillusioned at one point regarding how we do respond to people that do access healthcare through emergency services. Are we actually sort of responding to them in the best way we can? I didn't feel we were doing patient justice by the traditional model of popping somebody in the back of an ambulance and then dropping them off at the ED for further care. And I didn't feel challenged. I don't know if that resonates. I certainly just stopped, or didn't stop, but gradually felt less and less challenged in the role that I was doing. And a piece of research, and I think this is why research is so powerful for us, popping Nana back into bed by Paul Simpson in his PhD. He was investigating decision-making for elderly fallers amongst paramedics. And basically what came through and emerged completely from that was that role perception of individual paramedics affected the decisions they make and therefore the care for their patients. And I found that sort of quite powerful, how people perceived what a paramedic is. And I'm sure we all know, if you ask 10 paramedics what a paramedic is, you'll get probably 15 answers. So I'm currently now working in this community paramedic space, which Queensland Ambulance calls LARU, or Local Area Referral Unit. I feel I have lots more autonomy. I am able to deliver patient-centered care, and I work alongside some very experienced and knowledgeable paramedics, and we can consult with each other. So walking away from that, I feel much more satisfied now at work, as working with the patient towards what their next step is after I've had the privilege of attending them. And I'm very excited where this space is going. So this community paramedic practitioner space, both in jurisdictional ambulance services and in primary care. So to talk about the Grad Cert with QAS, now this is the entry level for LARU Paramedics. You have to pass an expression of interest, go through assessments, and also you're expected to complete a Grad Cert qualification that's been produced in-house. And it has gone through various iterations, but we've certainly got a very good model at the moment. And it seems to align very well with how we actually deliver care. So one module is clinical examination, enhanced assessment, and focused around patients with complex needs, not just an average person. This is the type of people that we go to. Critical reasoning, so starting to think how we think, acknowledge bias, etc. But how do we diagnose and then manage patients? And again, with those complex needs that we know are out there, often patients are elderly, comorbidities. One module is based on planning and facilitating those care pathways, so assisting patients navigate those. A focus that everybody likes is the wound care. We've got some enhanced wound care, and there's a very good course that we attend on there. There's linking with the local hospital service that assists us with that. And for some people, it's the final course, for some it's the first, but it's how we develop and maintain network and collaborative partnerships in the community. And that's an expectation of us as individuals. We do tend to get support from the organization, but that's part of our role. And as part of that training now, there are short sections of mentoring. So paramedics will, going through the program, will work with more senior paramedics, and part of the assessment is based on how they deliver care with a complex patients over several patients. It also includes clinical placement in local EDs and also GP clinics. So we're starting to sort of get a bigger picture of that health network. We're very fortunate to have ongoing PDP built in. So for us in the Sunny Coast, for every 8 weeks, we are given 1 8-hour day, clinic day. And that's for us to, for PDP, but mostly we use that extending and trying to collaborate with other services in the community to understand them more and share what we as LARU paramedics can do. And now we also have a monthly statewide meeting via Teams where LARU paramedics can share ideas, share experiences, discuss the local collaboration that's going on, and raise sort of common issues. And as part of that, there's also sort of clinical audit where someone will talk about a case and we'll break that case down. And the intent is just sharing this massive knowledge that we have amongst LARU paramedics. So role and scope, I find, is quite an interesting thing. Just to give it a bit of background, in my region, we have 2 LARU paramedics working each day in a van, as you can see. So it's a single officer response, and we cover hours of 7 to 2100. So 2 vans like that with a single paramedic. We also have a mental health co-responder model. They run out of another vehicle, and that's a LARU paramedic with a mental health clinician, generally a nurse, that will try and target specific cases. So there's been no real definition of LARU in Queensland Ambulance Services, as far as I'm aware. I still can't find a particular definition, but the comments that have come back is we're still doing the same job as expected of us through the Code of Conduct and what the QS expects of all paramedics. Probably across the state, my understanding is Brisbane Metro has LARU offices, the Gold Coast, obviously Sunny Coast, Cairns, Townsville, and soon to be at Mackay. And the organisation encourages the rural officers, generally single paramedics, to complete the LARU training. So we do try and target cases, generally those sort of looking like they're primary care type cases. Don't necessarily need 2 paramedics. Try and avoid the emergency resuscitation cases, but again, probably too commonly we're the closest unit. So we will respond as a single officer, a single paramedic, and perform a resuscitation as is expected by any paramedic. It probably happens way too often, actually. Wound care, we'll sort of try and keep our eye out for wound care jobs. And as I said, the mental health co-responder sort of tends to target the softer of mental health or social needs, so avoiding those ones with maybe acute behavioural disturbance or significant intoxication. The people that are probably going to need to be assessed fully in hospital, they tend to avoid those and target cases where they feel they can add value in the community. So we can self-dispatch, so we can see jobs literally as they come in and they start to rack up. A system called iRoam, so we can see the job and we go into the job and read more about what's going on, so we can maybe have a bit of a nuanced dispatch of reading between the lines of what's going on in a case. Here, Sunny Coast, that's probably about 50% of our workload is us attaching ourselves to cases. Obviously, the traditional dispatch model. We now have an evolving clinical hub, which, if I simplify that, it's a secondary triage system with some very experienced paramedics, doctors behind them, other areas of expertise. And again, they'll call cases back to try and get more information, which then sort of helps the ambulance service decide what's the best response model for these people. And that's expanding. So again, it's quite exciting times for us. And this has happened a little bit more. I chatted with David about his region. So crews are now they understand us and are a bit more aware of what our capabilities are and aren't. Crews are starting to give us a call or go through the communication center and say, look, I feel there's going to be value added if LARU came to this job. So often that may be wound care, people that are adamant they don't want to go to hospital or don't need to go to hospital, but some wound care is probably required. That's quite a common call for us. So the vehicle, we have changed vehicles, but we've still got one of these in the Sunshine Coast. Classic ambulance service. Let's see how much we can fit in a small space. So they seem to believe these vehicles are TARDISes. As you can see there, basically, if it's on an ambulance, it's in the back of our car. So femoral sprints, vacuum splints, full oxygen kit, full resuscitation capability. Interestingly, our extended scope and skills and medication, I would say knowing what to do about other services is probably a little bit limited. So wound cleaning and closure is probably a big focus. Simple interrupted suturing by consult, adhesive closure, again by consult, but classic skin tear work. And we do have lignocaine for infiltration for digital block or to assist with suturing or wound cleaning. So additional medications. With a medical director, he's very keen on thoracotomy. Certainly not going to give that to LARU, but I think to appease us, he did give us a ring cutter. So we're fairly well known for having ring cutters on board. Some enhanced dressings, as I said, lignocaine and loperamide. So a few extra drugs, but we're not in that space, as you can see, of catheter change or antibiotics and so on. And I think this is probably the key where Queensland Ambulance Service see us, and I sort of do buy into this quite a lot, which is our roles, the enhanced clinical examination and enhanced critical reasoning. And particularly, we are given time to assist with that. Time for me is probably the biggest asset. I can't believe, when you look at the whole health service as a paramedic, how much time we are given with an individual person. But we know the benefits of that in the long run if that person doesn't need to go to hospital and they're more suited to a pathway in the community. Not only is it probably better for them, but from a resource point of view, there's some significant savings. But we're very privileged with the amount of time that we can spend with people. Again, the service its model is not to replace any existing services or provide services that other parts of the health system should provide. And I think that's why we've got some limitations on what we do. Whether that will expand in the future now that this Grad Cert is becoming more and more a standard. So there's a certain sort of credentialing of LARU at the moment where I feel we may move into a different space in the future. So how do we work? It's probably, I don't want to teach anyone to suck eggs, but I'm just going to describe sort of what we do in our world. So obviously people with unscheduled healthcare needs or feel they're in an emergency situation will seek help, and we're very trusted and people will call the ambulance for that. There's an expectation and not necessarily a need or a want, but people do feel that the ambulance, once they come, they're going to go to hospital. And it's not necessarily what they want as an outcome, but they feel that's a normal sort of traditional response. Once you call the ambulance, pick up, go into hospital. So we sometimes change those expectations, and that can take time as well. So the time is valuable. Generally, my aim really is to build up a lot of rapport, is build up that trust very early on. If I don't need a blood pressure, if I don't need vital signs assessments, they're put to one side. We can do a visual survey very, very quickly and see if that person needs me to escalate my care higher, or if I've got time to sit down and have a bit more of a chat. And that really values, because people then do open up and they start to tell you that bigger picture, the whole story of what's going on, not just the incident that's maybe triggered the call to the ambulance service. And for me, significantly, is in the back of my head is why did this person call 000 for something that could be treated in primary care? And that's not a criticism, that's my bugging question, really, a little bit of a protective, what's going on here that made this person feel this was an emergency? So we tend to perform extremely thorough clinical assessment, examination and history taking. We will build up a provisional diagnosis and a list of differentials. For me particularly, I find it an uncomfortable space because we don't have diagnostic tools. So making a diagnosis is actually quite difficult, but we can certainly risk stratify about what's going on with that person, and start to then consider what does that person actually need? What are their particular needs? How urgent is it? What are those barriers that are stopping them accessing healthcare by certain means? And treat them as an individual, not as the sort of biomedical model. What's going on for this person in front of me today? Then the consideration is what services are available to them, what's suitable. Obviously 2 o'clock in the morning, fortunately we don't actually work at that time, but we're going to have limitations of services that are going to be available. So what will the ED do? Are the person's expectations of the ED going to be much greater than they believe them to be? Certainly, what are my risks if I don't transport this person? How time critical are they? And what services are available for me? So if we do decide to go down a pathway that's not taking someone to ED, I have a few safety nets that I tend to put in place. The very first one really is, it's a self-check. Why do I believe the decision that I've made to be the best for this person. So I try and identify any biases that might have affected that decision and make sure I'm actually being honourable and I'm doing the best for this person in front of me, and not being affected by other things that I shouldn't be allowing to consider into my decision making. Generally, we'll provide advice and recommendations, but obviously also involving patient substitute decision makers and so on into those options for care. Obviously, it's a line we use often, which is you can always call us back, but I think that's a little bit of simplification. So generally, I'll leave people with a clearly defined plan, which involves specifics of if X happens, then you need to do this, rather than just a general sort of if you deteriorate, if you don't feel well, call us back. It's give them a specific set plan. They know when they can call us back. And building into that is either get the patient to write down those instructions themselves, so that stays in. As we all know, probably only about 5% of what we say to somebody goes in. So written information for me is very important. We do have a series of QR codes focused around sort of wound care for leaving someone, to give them advice when to call us back if they need to, and what to do in terms of that wound care, or point them in the direction of how to access appropriate information online, which, as we all know, there's certainly hazards of sending people just online. So use Queensland Health patient information sheets, very easily accessible, very clear, variety of languages, very easy for people to follow and understand if they've got those questions once we've walked out the door and they're not quite sure what to do next. Torn between this one. So often I do try and encourage the person themselves to make a GP appointment if I feel that's suitable. So help them download things like HotDoc or My Health Engine, just to raise awareness that there are more services than they possibly perceived available to them. Can be a bit of hit and miss. This is more about me trying to empower the person to take responsibility sometimes. But again, we do value speaking to a GP with a clinical handover and a good description of what's gone on with that person. Tends to build up a lot of trust with us. And I've found in the Sunshine Coast that the GPs are extremely receptive to us. So there's a balance between my decision on that one. Certainly try and make sure that somebody can check in on that person. It might just be a family, friend, or neighbor who can just knock on the door and check that person's okay. Try and line something like that up. And we often in the Sunshine Coast call patients back. So within a certain time period, we'll gain consent. And that gives us a little bit of feedback about what's going on with that person, but it also allows us the opportunity just to sort of put a further safety net in place. And I've found patients value that immensely. So it's a very good tool. It's also a good feedback tool. So what options have we got on the Sunshine Coast? Traditionally, LARU, we're a little bit limited in particular pathways. We tend to sort of navigate each person's needs as we go along, and slowly as this build up with the PHN to try and make some pathways. I find the GP is the gold standard. That's what their job is. They're the navigator for the individual. They follow them over a period of time. They can see what's going on with an individual and build up that trust. Some pathways on the Sunshine Coast. We have RAS, which is a residential aid support service. This is consultant geriatricians that are on the telephone to RNs in aged care facilities and can offer them advice if they're considering sending a patient into hospital. They also have a nurse practitioner-led team that will go out to the aged care facility and try and offer services that the person doesn't necessarily need a transport into hospital for. They're a fantastic consultation for us. If we've been called to those facilities, we can speak to that geriatrician, we can speak to the nurse practitioners and talk through our decision making and see if they'll either come out and help or, again, just gain from their knowledge. Sony Street's a local referral pathway, fantastic organisation, originally set up delivering care to homeless and vulnerable people from the back of their vehicles, or their own cars, their personal cars, and that's developed into having a health centre in Maroochydore. This place offers very holistic services. It's a very nurse conversation-led approach. There's always smiling faces. they deal with people and assist people with their social needs as well as their health needs. So it's a very holistic centre. There's access to showers, food, clothing. They can support sometimes with shelter, but I think we all know how difficult that can be sometimes. And build up some significant trust with people who sometimes feel threatened by normal healthcare, or they feel there's bias in normal healthcare. We also have the mental health co-responder model, as I explained before, and they tend to dispatch to certain cases, and we can bring them into our case if we need. And this is an area in, I talked before about ED placement. So we've built up a local relationship. We've got a fantastic doctor that's supporting us for clinical placements for LARU Paramedics in ED, fast track or front of house setting. And also nurse practitioners can come on observation shifts to LARU. So the knowledge sharing is fantastic. The exposure for us to see cases, we might see 5, 6, 7 cases a day working on our own. In here, we could see that in an hour and have experts available to us to talk us through their decision making. So it's a great opportunity for learning. I'm just aware I'm going to go over time a little bit, but I just want to talk about these pathways from the patient's perspective. Too often I feel we think about resources, the ED's busy, etc. So what does it mean to the individual? So I'm just going to go through a few case studies, and I'll try not to take up too much time, but obviously the patients are anonymized. These are sort of generic stories emerging of different people's situations. So the names have obviously been changed. They're not real circumstances, but they're certainly an average case that we go to quite often. So Enid is an 88-year-old. She lives in an aged care facility due to some mild dementia. On this occasion, there was a case that popped up. It was 2A, which means an ambulance response without lights and sirens, but urgent, or no delays. And I spotted this case and I thought, hang on, do we need an ambulance going to this lady? So I've attached myself to it. The history was a fall during the night. She's managed to get back into bed. However, the nurse in the morning has spotted she's got a little bit of swelling to her wrist, doesn't seem to be in any significant pain, but did notice some pain on palpation, and quite rightly wanted to advocate for Enid and make sure she got some full care. So she called an ambulance for her to be assessed in hospital. They had called a daughter to sort of explain what was going on, and the daughter said she wasn't able to come out until the following morning. So when I saw Enid, we did have the option of going to a local hospital. It's notorious for not accepting ambulances. It's sort of funded in a way where it does have to accept some, but quite often they're very busy. So the next ED for Enid would be 45 minutes away. So that's a journey with me, somebody she doesn't know, and probably several hours in a hospital that's uncertain, unfamiliar to her. She's probably unsure why she really needs to go. Her confusion may be increased. It's very likely she would be ramped for a while, given the sort of workload of the hospitals. And there's a danger that Enid would deteriorate, decondition, possibly not get fed and watered or bathroom as frequently as maybe she should. So that's one option. Fortunately, I was able to contact the RAS team and spoke to the nurse practitioner. I was aware that they've got a mobile X-ray. So my thought was, great, we can have the X-ray brought to Enid. Unfortunately, they sort of advised it probably wasn't going to be available for about 3, maybe even 4 days. And we felt that was probably not a suitable time period just to sort of leave this without assessment. However, they were good with knowledge and advice and sort of seemed to sort of consider that this would be something that was suitable to wait until the following day. So again, this is consulting with the patient themselves to a degree, the patient's daughter, who was the substitute decision maker, and the RN, and contacted the patient's own GP, asked that they made a referral for X-ray. And funnily enough, that's in the local ED. And organised that Enid's daughter would actually come and collect her first thing in the morning and take her for X-ray. So she'd be with someone that's familiar, she'd be comfortable, and she'd be with somebody that could advocate for her. In the interim, she was given some mild analgesia, although we didn't really think she was in significant pain or pain would have required any further analgesia. But the RN was fantastic, was quite happy to take a little bit of extra care, keep checking in on Enid. And the plan was put into place. I put a little splint on her wrist just to protect it, really, just in case, obviously, she wasn't aware of what had gone on there. And yeah, excellent case. It saved a lady going through an ED system that she didn't really need to do. I talked about Sony Street. That's Sonia. She's an RN. She's one of the co-founders, and that's exactly the sort of welcome anybody gets whenever they appear anywhere near Sony Street. Non-judgmental, absolutely very caring, trusting environment. Similar case where something's popped up on the board, thought, does this person need an ambulance, 2 paramedics? Maybe I'll go out and see what their needs are. It wasn't urgent. Again, not lights and sirens. And there's a chap called Dave, 43-year-old homeless. And he'd actually called, he'd asked staff to call from a BWS bottle shop. He suffered some chronic and complex background, alcoholism. He did have a little bit of reduced mobility due to his leg pain. But on full assessment, it seemed to be more chronic leg pain that was a little bit exacerbated rather than anything sort of particularly acute. He'd had some alcohol, but wasn't particularly intoxicated. He'd also run out of his standard medications. He did have somewhere to sleep. He was couch surfing, so he did assure me he did have somewhere to sleep. So I realized there was no urgent priorities. And I was aware of some recent research that showed us lived experiences of people that are homeless going through ED. And their lived experience tells us things like they do experience stigma. They feel there's a bias against them. They don't feel treated as an individual. Often they're sat in a cold waiting room for several hours and maybe given some sandwiches. And this is the particular thing. They feel that their underlying social issues that have led up to the complaint are never really addressed well. So the alternative I was able to organise for Dave was to phone Sony Street. He was able to have a shower, get some food, recharge his phone. And here now we've got a person that feels cared for. He had his script supported, so he was able to sort of get hold of the medications he needed. And he's got somewhere he can trust. So when he does sort of feel times where he's not so great, he can pop in there, sit down and just have a chat if he needs be. And what was rewarding for me was the sort of visible relief and comfort that you can see slowly emerge from a patient that's possibly untrusting, but slowly starts to open up their vulnerability and starts to realize they're in a safe place. I'll talk a little bit about the mental health core, and this was a colleague talked to me about this case. So again, very de-identified, very mixed up from story, but quite a sort of a common situation or a certain situation. So Steve's a 30-year-old, lives independently at home with partner and children. The job was a 2A, mental health, suicidal. What basically had happened is a partner had called, concerned about his behavior, mentioned suicidality. The patient had left home and not returned, and that's when they'd called the ambulance, but had returned home prior to the mental health team attending. So once the mental health clinician had spent some time with Steve, over 90 minutes, he was able to open up and sort of acknowledge that he was in significant stress due to work, significant financial stresses, as well as having a young family, and opened up that he wasn't coping. He had recognized something was going on, but didn't really know where to turn to, and had approached his GP and been given some citalopram. Again, recognized he was in a very dark place. Wasn't intoxicated. He wasn't actually hadn't self-harmed, and he was open to discussion. But he was very, very concerned about others' perception of his situation. He felt very vulnerable and wasn't sure how he could open that up to anybody, and didn't really know who to trust to talk about that, and was very, very reluctant about going through a hospital ED environment and having to tell his story to strangers that he didn't know, and possibly several different strangers. So once trust was gained, they were able to dig a little bit deeper, identify some risk and risk stratify with Steve, performed mental status examination, and that's by an expert, the mental health clinician. and considered sort of safety factors. He didn't actually have a plan. He did have suicidal ideation, and he'd returned home because he had something there that was worth living for, and that was the reason that was keeping him fine. As I said, ED they felt was going to actually exacerbate his situation rather than support it. So this chap was able to stay at home with his family in this very emotional period. Other family members were coming home to support his family as well. A mental health acute care team saw him later that afternoon, and they put in place several plans for him in terms of contacting him each day, every day, and counselling for his family as well. So they had access to support services, and he was quite concerned about that. The mental health co-responder also kept in touch with Steve, Dave, Bill, whoever it may be, kept in touch with Steve throughout until the acute care team attended, and that was just the odd telephone to make sure how he was going. The outcome of this to me is very significant. So he could have gone through hospital, he could have got the same service, but the patient and his family are just so grateful of the support they'd achieved in his home rather than the exacerbation of his circumstances of having to go through ED. And my colleagues sort of mentioned they felt if he'd have gone through an ED environment, the next time this may have occurred or his situation may have deteriorated, he may have been reluctant to even call an ambulance, or would have avoided, kept out of the way so that the ambulance couldn't talk to him or force him to go to hospital. So I think very significant service there. And just briefly, classic situation, young 5-year-old girl, Rosa, banged her head in the cupboard, laceration, not bleeding. Father's called the mother who wasn't there, and the mother said, "Can you call an ambulance?" I've attended, put myself on the case. There's a 1 centimetre vertical lac to her forehead, performed a thorough neuro assessment, and this was about an hour after the incident, pretty much asymptomatic, a little bit grumpy, but easily relieved with Panadol. This was Saturday, 4 o'clock, unlikely that a GP would take on further patients. However, I think if they presented, they probably would look after her. Could go to ED. We knew it was busy, would probably spend several hours in there. And is that the best place for a 5-year-old on a Saturday evening? So discussed the case with the father, offered to close this with adhesive, and also suggested that we phone Rosa's mum and have a chat so I could introduce myself, tell dad exactly everything, what we could do in the home, and gain mum's trust. So she was quite happy for the process to occur as well. So yeah, pretty simple, straightforward case. That was closed with adhesive. We do have to consult for that, probably 30-35 minutes, and advice was given. Father was given a QR code where he could access follow-up advice for this situation, and sensible father, sensible mother, yeah, they would follow up with a GP as soon as they could on the following day, following Monday. So I guess those case studies for me tell a story of where I'm from in terms of paramedic. And I'm sure this resonates with pretty much everybody that's listening, which is this is about the patient, regardless of the resources that are available. We do know it may be beneficial for people not to attend ED. ED can be harmful for some individuals, but we possibly need a bit more research around this. And that led me to looking at patient-focused research. Again, I'm a little bit aware of time, but just talking ambulance services historically see non-conveyance as very negative. It's risky. There's a lot of time. And there's also sometimes this bit of a sort of culture of we shouldn't really be attending these people in the first place. And that, if I'm honest, goes through from paramedics through to certain areas in management. I'm not saying just with us as a service, but generally across services. And that's possibly due to our background and culture. We're definitely changing, and that's not a criticism. So with working on the LARU, I started to question how effective are LARU community paramedics in Australia. There was a lot of work in Canada, for example. So sort of this led me down the very slippery slope and into a deep pit of doing a deep PhD. And one systematic review, Eben 2017, looked at patient safety and professional perspectives on non-conveyance. Patient safety was interesting because this was measured as death as a negative outcome, which clearly it is, but is that really the best measure we've got of services we provide? Did they die or not? It's obviously a very rare event, and in fact, some people might have wanted that as an outcome. I prefer to die at home. We certainly know palliative care is a growing area for paramedicine as well. Another measure was like, did people access emergency care within 24 or 48 hours? Yeah, maybe you could argue that's a reasonable measure, certainly from a resource perspective, but we don't know why. And it could have been part of the original plan with the paramedic. It could be that they have deteriorated. So the original decision was perfectly fine, but the patient has deteriorated. And here we are, they're following a perfectly acceptable, reasonable plan and escalating their care. So is that a negative? So I performed a scoping review of myself as part of the PhD. I won't sort of go into too much of the details of that. It is published and you're certainly welcome to read that. Basically just looking at research that looked at the patient's experience of non-conveyance after they've been attended by an emergency ambulance service. From that, value was certainly noted in there about the experience. So there was something being given, there was medical care being provided because patients valued it. Although sometimes these are seen traditionally with some paramedics as being non-jobs. It's a non-transport. Is that a job? I don't use my skills, my interventions, but there's significant amount of care being delivered. There's significant assessment and reasoning, rationale, safety netting. So quite thorough care being provided. Obviously, it sort of pointed out that research of patient experience in paramedicine was very limited. And if we compare that with medicine, nursing, midwifery, they've got decades of it. We've got a handful of studies, and particularly a handful of studies about patient experience of paramedics when it comes to non-conveyance. So my questions then were, well, if we're not exploring what patients experience from paramedics, how on earth do we know what our patients expect, what their needs are, or what are those experiences? So then how do we train paramedics? How do we educate paramedics? And how do we respond? How do we design response systems accordingly? And then certainly, how do we measure the value or outputs of new initiatives such as LARU or community paramedicine, ECPs? How do we measure those from the patient's perspective? I'm sure cost analysis is in there somewhere, but are we actually asking the patients? So my current PhD, is basically aiming to explore patient experience of non-conveyance. And so far, I've been fortunate to interview 21 people. I can't really go into too much of it, but there's definitely significant value from their experience. There is a symbiotic, huge experience from a professional and friendly care that paramedics seem to give her. And even when there's a negative experience of people, there's still actually lots of value in some of the care paramedics provide. And people go from this transition of feeling unable to cope, or they're suffering an emergency, receiving this significant care, and then being able to believe in themselves to continue at home, and often very grateful that they didn't actually have to attend the hospital in the first place. So I'm also sort of through this, I've been able to explore those people that do sort of re-attend hospital, and try and find out sort of what's gone on and why there. So that will be one of the outputs of the research. So for those keeping an eye on time, I'm sort of almost there. So as a summary, I think for me, this rings so true, and it's a colleague, and I'm sure it's been said in many other places, but we've traditionally been governed by our employers, which are jurisdictional ambulance services. They've designed how we train, how we operate, and what we do. And now we've got to this stage of adolescence, say, or maturity, where we're starting to explore what we can do as a profession ourselves. So research is out there. Where can we lead this? Where can we go from here? And maybe sort of shake off some of those tethers. And I'm sure the organisations, ambulance services, are also there forward thinking, looking at how do we fill this space. We realise it's a significant part of our workload. But what I'm saying is I feel that we need to push that forward, and organisations such as the ACPP is certainly significant in that. So for me, LARU with QAS is the current focus is certainly around critical reasoning, and hopefully maybe some enhanced scope in the future. Community paramedicine as an umbrella statement for ECPs, LARU, all sorts of aspects, is definitely evolving, expanding, and I feel we have some responsibility to also lead that as paramedics. And I'm probably not talking to necessarily the right cohort here, but as paramedics, I think we really do need to focus on the patient's journey and not based on what our role perceptions of what a paramedic is or isn't. We've certainly moved on from there. So thank you very much for listening, and I thank you for the opportunity to tell my story about LARU. I'm certainly open to questions, and there's a little bit of a bibliography slide there if anybody wants that.
Just fantastic, Robbie. Thank you so much for your really fantastic presentation. It's a really interesting role, the LARU space. Extended care and community paramedics around the whole country are really starting to come into their strides and getting more attention and demonstrating their value. And as you were also demonstrating, there's a growing body of research into this position as well, which is just going to further enhance it moving into the future. We do have some questions, Robbie, so I might just get into those, and I'll start off with one of the people who are here live. And the question was, is there any additional geriatric specific education provided during the LARU course?
That's a fantastic question. I would argue not. And it certainly would be a very valued aspect. Again, and Dave, I do know, just to sort of leak a little bit here, does have involvement in the program, so maybe I'll sort of see a bit more. My experience is we haven't had that. However, when we do case studies, assignments, they are based around particular vulnerable people. So we're expected to demonstrate knowledge of complications with, say, the elderly person or the older person. That is expected of us.
Yeah, okay. Robbie, what role do you feel a prescribing paramedic practitioner might be able to play in an ambulance service environment like what LARU does here? In particular, I'm interested in the difference between metropolitan and rural and remote practice, and how senior paramedics might be able to fill those healthcare gaps. So I guess we're talking about paramedics with prescribing levels of care. This is something that is developing as well. What do you feel that skill set might be able to add in a place like the Sunshine Coast versus a rural or remote environment? I'm happy to keep that within Queensland in your experience as well.
That's a fantastic question, isn't it? Like we're expanding. There's what's going on in the community. There's what's going on with jurisdictional ambulance services, and we're quite aware of things like GP shortages. So yeah, fantastic. Well, certainly in rural areas. Yeah, I'll be honest. I used to be quite hot on this. I'm probably less so, but I certainly believe there is a role for jurisdictional ambulance services to consider practitioner. Even to the point of consultant paramedic as well. I don't know if that's a term that would be sort of accepted, somebody that people can refer to. In terms of having particular enhanced skills, so for example, independent prescribing of antibiotics, for example, being able to sort of bill. In a metro area in Sunshine Coast, I think we do generally have sufficient local resources that someone's not going to be, a decision's not going to have to be made. Do we need to put this person on a plane for 4 hours? Or do they need to be taken out of the area for their own safety? So we're fortunate that decision making is not quite as complex with that. The referral on is usually the GP, primary healthcare network. On saying that, we have solar powered doctors and don't seem to work on weekends sometimes. So there's still those sort of gaps in the community that do cause a few bottlenecks, I think. And in the health system as well, it seems to sort of shut down on a weekend. So we don't have sort of patient flow. So getting away from your question, I probably agree with what you said there. You've separated metro and rural. I think rural, absolutely 100%. You've got a paramedic. I don't know how many jobs they may do in a particular area per year. I guess my belief is they're fantastic paramedics, and when they get asked to perform, they do. I'm not so sure how frequently they would roll out. So surely they can provide other health services in those areas where the gaps are, and whether that's specifically independently or supported practice. There's various options. I'm not 100% in terms of an independent practitioner from a jurisdictional ambulance service. I see as an ambulance service may see particular risks in that rather than the benefits, but a supported practice through consultation maybe. And they're just my thoughts.
Yeah, great. Another question here, Robbie, is does telehealth have a place within LARU? And I know there's recently been some publication and promotion nationally regarding Queensland Ambulances clinical hub and the ability for them to do some callbacks, which also include Visio callbacks as well. But what is your experience in LARU? And perhaps as well, we can extend on that a little bit further. What about your experience with telehealth after you've been, or you're with a patient and maybe doing a telehealth or referral call to another practitioner?
Yeah, great question. I think there's certainly sort of space for that. I have brought in a patient's GP to the conversation in a case, back pain. There were no red flags, basically did need some additional medication and a little bit of support. And there was a little bit of hesitancy maybe to trust my advice as a paramedic. So we brought the patient's GP in, had a three-way conversation, and that certainly was a fantastic opportunity. I think the GP still got paid. The patient went down the best pathway for them. And I guess for me, we didn't take someone into a busy sort of hospital system for something they didn't really need to be there for. Yeah, again, I'm more for consultation. I feel sometimes we're a little bit exposed as a single paramedic, and people have a lot of trust in us. I think we are highly skilled, but we also have to acknowledge we have limitations as well. So the opportunity to bring experience into a case where I can be the hands, ears, eyes, assessment tools, whatever, for someone that's based somewhere else that doesn't actually need to travel out to that person or the person travel to them, it's clearly the future. So I think being there present as a paramedic and having that support good. I do have a little bit of hesitancy. You were talking about this the other day. I think as paramedics, we can walk into someone's house and get a feel that something's not quite right. Or we can build up trust with a person and they reveal to us something that we wouldn't necessarily have got over the telephone. So there's a balance here. We can't sort of offer an ambulance service to every single person. And I think that the secondary triage is appropriate, but I'm just cautious about some cases where a human being sat down talking to another human being is valuable as well.
Thank you, Robbie. Another question here. There are a growing number of master's programs in community care paramedicine and paramedic practitioners as well. The question here is, there's actually 2 or 3 questions that are built into it, but I guess the crux of it here is, where do you see education going in the future for community paramedics and paramedic practitioners? You did touch on before that Queensland Ambulance has an entry-level graduate certificate requirement for its LARU programs. That is run in-house and is a growing modality of study. It's something that is required of all of the new onboarding of LARU paramedics. Where would you like to see this training go in this particular specialist space of paramedics? And let's think outside of just ambulance services, but in any field. Do you think it needs to be, or it should be, graduate level program, masters? What is your opinion?
Yeah, and this is opinion. I'd probably say people like yourself, David, are a much better position, and people in the ACP better position for that question. From an opinion, working in the tertiary sector, tertiary education, looking at the expectations of paramedics, I guess I personally would be much happier with a national curriculum for paramedics. That way you've got a foundation where you know everyone's had a certain amount of training. And I know there's accreditation standards in place, but I'm talking about a curriculum a little bit more focused. I think that would be great. I think integrating that with placement over 4 or 5 years would be even better. But that to me is the foundation. And then absolutely, when we're going into these specialist areas and making decisions that can be very risky decisions to leave someone, we're delaying care for some people, and that can be a very risky decision. And we don't know what we don't know. So yes, we do need higher credentialing, I feel. So certainly Grad Cert, I feel probably even a minimum for roles fairly semi-autonomous as this. And as you say, sort of, yeah, it's certainly into master's level. I feel that would be appropriate. But again, I guess we've got to look at the evidence. What does evidence tell us about how people do learn, what their capabilities are? Yeah, it's just an opinion.
Yeah, and to finish that off for the viewer here who's mentioned the question, there are a series of masters around the country. I won't name all the universities because it's too long to name right now, who offer paramedic practitioner masters. Also community care specialist streams are being offered. So yes, there are certainly courses out there. Deakin is one that comes to mind at the moment that does offer a paramedic practitioner course, which has some prescribing units in there. And I think the future is very bright in that space. Robbie, thank you so much for having a chat with us today. It's just fantastic to lean on paramedics with experience like yours, and certainly the LARU model is really innovative. It's been around about 6 or so years now, maybe 7 years within the Queensland Ambulance, and it just seems to be growing as as the years go on. And it's just a great opportunity to have a chat to you, and I really wanted to say thanks for your time today.
Honestly, the privilege is all mine. I've just sat here talking about what I do, and I'm very satisfied in my job. So I appreciate the work that you're doing, David, and also the college as well. So yeah, and thanks for the questions, some really good questions.
Not a worry at all. Thanks, Robbie, and for everyone viewing, hope you have a good evening. Take care.